Hey students, it's Dr. Gress again. And in this short lecture, I want to talk to you again about the anatomy and innervation of the eye. This time I want to look at internal structures of the eye, so structures of the eyeball itself. So first of all, let's take a look at the various layers that compose the actual eyeball. So the actual spherical hollow structure of the eyeball. The outermost layer is called the fibrous tunic. Now, a tunic is a word for sort of like a coat. So when we say a tunic, that means like a coating of the eyeball. So the outermost coating or layer or tunic of the eyeball is called the fibrous tunic. And over most of the eyeball, this is composed of the sclera, which is a tough white layer. And that's what we can see when we look at the whites of our eyes. At the very front and center of the eyeball, though, the fibrous tunic becomes clear, transparent, and this part is called the cornea. So the cornea is the part where light enters, the first part where light enters the eyeball, and there's some refraction or focusing of the light that happens there. As we go in deeper, so the tunic, the fibrous tunic is the most superficial layer. As we go deeper, the next layer in is the vascular layer. This is, in other words, the layer where lots of blood vessels are found, the blood supply to the eyeball. And the majority of the vascular tunic is made up of the choroid. So that's the second layer that you can see right here. And again, that's where most of the blood vessels are found. Again, though, we have different things happening up at the anterior portion of the eyeball near where light is going to enter the eyeball. First of all, the vascular layer or the vascular tunic right at the front in the center is specialized into a muscular aperture made of smooth muscle called the iris. And this is the part of the eye that's colored, can be anything from pale blue all the way to dark brown, almost black. So that's again made up of smooth muscle, and we'll talk a little bit more about those muscles in a minute. At the center, so that's basically a sphincter type muscle because it's a circular muscle. And at the center of it, there's a hole, and that hole is called the pupil. So the pupil is the part of the center black circle in our eye that we can see when we look into someone's eye. And that's actually an opening into the interior of the eyeball. Finally, around the edges of the iris, attaching the iris to the rest of the vascular tunic and also attaching onto the lens, which we'll talk about in a couple of minutes, is this structure here called the ciliary body. And that ciliary body is also primarily composed of smooth muscle, in other words, involuntary muscle. So together, those structures make up the vascular tunic or the middle layer of the eyeball. Finally, the deepest or most internal layer of the eyeball or tunic of the eyeball is the neural tunic. And of course, you're probably aware that that means it has to do with nerves. So the neural tunic of the eyeball is the retina. And the retina is, of course, the light sensing organ. So this is where the receptor neurons are that sense light. And the neural tunic or the retina is connected at the back to the optic nerve. So the retina is actually basically an extension of the optic nerve and sends sight signals through the optic nerve back into the brain. So those are the tunics or layers of the eyeball. Now, within the eyeball, within that hollow spherical structure, we have a number of sort of areas, cavities or compartments, and these are called the cavities and chambers of the eyeball. The larger division is into anterior and posterior cavities, and basically these are separated from each other by the lens. The lens is a flexible, transparent structure behind the pupil. So here's the iris, which remember is a ring, but we're looking at it here in cross section. In the middle of that ring is an opening, and that's the pupil. So directly posterior to the pupil is the lens. And so that's this biconcave. In other words, it's sort of disc shaped. It's biconvex. It's convex on both sides, disc, okay? As I said, it's sort of suspended from the ciliary body on each side. And the lens is an elastic structure that can actually change shape. And by changing shape, it can help focus light onto the retina. So the eyeball is divided into anterior and posterior cavities by the lens and the ciliary body, these little ligaments that connect the ciliary body to the lens. So posterior to the lens is this large area that makes up about 2/3 of the eyeball that is called the posterior cavity. It contains a gelatinous substance called the vitreous body. Sometimes I used to hear it referred to as the vitreous humor. More often you hear vitreous body. It's clear also, and it's does some magnification of the light coming through, but basically it's this gelatinous sort of blob that fills up the posterior of the eyeball and gives structure and support to the whole back of the eyeball. So it's a little bit like the water in a water balloon or something like that, or a pillow inside of a pillowcase, if you will, that's filling it out and giving it structure. Anterior to the lens then is the anterior cavity. And the anterior cavity is filled with a liquid, a clear liquid substance called the aqueous humor. The aqueous humor is actually secreted by cells in the ciliary body, and it circulates throughout the anterior cavity of the eyeball. It actually also circulates around the edges of the vitreous body as well. It brings nutrients to the internal structures of the eye and also removes waste from the internal structures of the eye. It will eventually drain out into veins, so enter the blood supply from there. The anterior cavity is subdivided into two chambers by the iris. So anterior to the iris is an area called the anterior chamber, and posterior to the iris is a little area. So this is kind of sandwiched in between the iris and the lens, called the posterior chamber. Oops, I thought I had something on here about glaucoma. I thought I had it on here, but I do here, sorry. Glaucoma is one relatively common disorder of the eye that's fairly dangerous, can actually cause blindness. What happens when with glaucoma is that aqueous humor is secreted, but it doesn't drain out properly. But the drainage sites usually become blocked, so it can't drain out properly. And what can happen then is the aqueous humor can build up in here and actually put pressure on the lens, and from there onto the vitreous body, and from there onto that retina. So that buildup of aqueous humor can actually essentially end up pushing all of those structures backwards onto the retina, and that pressure on the retina can ultimately cause blindness. So it's important in cases of glaucoma to make sure that that aqueous humor is removed, that can drain out. So sometimes that can be treated with medications. In other cases, it's necessary to make a small, actually small hole in the iris so that that aqueous humor can drain out of there properly and not put too much pressure on the retina. One other relatively common disorder of the eye has to do with the lens, and this is called cataracts. So this lens is clear to begin with. You know, when you're younger and throughout most of your life, this lens is made up of a clear substance. But as you get older, or in some cases, even in younger people, that lens can become clouded. It can become more opaque. And when that happens, people appear to have milky eyes. This happens fairly often with dogs. As they get older, you often see older dogs have sort of milky looking eyes. And what that is cataracts. So the lens becomes clouded and opaque. And if that happens, it's like trying to look through a frosted glass window. Basically, instead of a clear window to look through, you've got a milky sort of window to look through. And so, of course, that interferes with vision. If necessary, lenses with cataracts can actually be replaced now with an artificial lens that's clear and can restore vision. So that's a relatively straightforward way to fix that problem. So now that we've sort of named all of these different structures, let's talk about how light moves through the eye, because of course it's the passage of light through the structures of the eyeball onto the retina, and the way that that beam of light or that light gets modified by the structures of the eye that allows us to see. So the retina will ultimately sense those that light coming in and striking it, and those sensations will be transferred to the brain where they'll be interpreted as vision. And you'll hear about that in another lecture. But let's just talk about all the various structures that light passes through before it gets to the retina. So again, remember the posterior cavity is back here behind the lens. The anterior cavity is in front of the lens, and that's divided into an anterior and a posterior chamber right there. So what happens first is that light enters the eye through that clear part of the fibrous tunic called the cornea, that clear covering on the front of your eyeball. And actually the cornea has about 2/3 of the focusing power of your eye. So a lot of the focusing of the light onto the retina is done by the cornea. However, the cornea can't adjust. It can't change to focus on things, say at different distances or whatever. That job is going to be done by the lens. After passing through the cornea, the light will then pass through this aperture that is the pupil, and the pupil can get larger or smaller depending on how much light is present based on adjustments made by the iris. So the iris in this picture is brown. In cases where there's a lot of light, the pupil will get smaller so that not too much light comes through. In cases where there's not very much light, the pupil will enlarge as much as possible to get as much light as possible into the eye and allow you to see as well as possible. So you're no doubt familiar with this phenomenon. If you got up in the night and went into the bathroom and flipped on the light, you would see that your pupils were very large. It would seem very bright in the room, but very quickly your pupils would get much smaller. And that's because your iris is contracting and making that hole smaller to compensate for the change in light levels. Now, after passing through the pupil, light will strike the lens. And the lens, I'll go into this more in just a minute, but the lens, as I said, can actually change shape, which is called accommodation, which can help to focus on objects that are closer to you or farther away from you and help focus the light properly directly onto the most acute part of the retina that allows for the most acute vision. So after passing through the lens, what's going to be here filling up this posterior cavity? That is going to be the vitreous body. As I said, that's a clear gelatinous sort of blob, and it magnifies the light somewhat before it gets to the retina. Finally, that light will strike the fovea, which is this pit-like place on the retina that has provides for maximum clarity, and you'll hear about that more in another lecture. So the light strikes that fovea on the retina. The photoreceptor cells, those are the sensory neurons of the retina, are going to respond to that light and send signals back through the optic nerve, cranial nerve 2, back to the brain. So cranial nerve 2, the optic nerve, is the nerve that provides us with our special sense of sight. Now, let's talk a little bit more. So in the last lecture, I was talking to you about extrinsic muscles of the eye, and those are those little muscles that attach to the outside of the eyeball and move the eyeball in different directions, right? Intrinsic muscles of the eyeball are muscles that are inside of the eyeball itself. They modify the shape of structures that the light passes through in the eyeball, specifically the iris and the lens. These are involuntary muscles. So those extrinsic muscles that we talked about last time, obviously those are voluntary. You need to be able to choose where to look, right? But these little muscles inside of the eyeball are involuntary smooth muscle. So you cannot control them. And they are innervated by autonomic motor nerves, not voluntary motor nerves. Primarily, the intrinsic muscles of the eyeball are going to receive parasympathetic motor innervation from the oculomotor nerve, cranial nerve 3. And we saw that one before because that nerve also supplies voluntary motor innervation to most of those extrinsic muscles of the eye. So that's solely a motor nerve, but in this case, it's providing parasympathetic motor innervation. So there are a couple of types of muscles that are helping us to see better by moving these little, or by changing the shape of structures inside of our eye. First of all, within the ciliary body are these little, what are called ciliary muscles. As I said, these are smooth muscles, and they attach to the lens by tiny little suspensory ligaments. So tiny little ligamentous structures. When those muscles contract, they pull on the lens and change the shape of the lens. And that's primarily what allows us to look at things that are closer or farther away. That's called accommodation. We'll talk more about that in a moment. And again, these ciliary muscles are receiving parasympathetic motor innervation from cranial nerve 3. The other set of muscles are in the iris. So here is a diagram of an iris. Here is an iris that's opened the pupil maximally, so it's dilated. And here is a picture of an iris that has constricted the pupil, made it smaller. There are, as you might expect, the dilation and constriction of the pupil are going to be, remember, they're both under autonomic control, but they're going to receive stimulation or innervation from parasympathetic in one case and sympathetic nerves in the other case. So opposite actions, the opposite types of autonomic nerves. Now, if you think about it, you might be able to figure out which of these, dilation versus constriction, is caused by sympathetic stimulus. Think back to last semester and remember that we call our sympathetic autonomic system our flight or fight system. So flight or fight responses, what happens when we're in danger or something, something dangerous or hazardous is happening that we need to react quickly. Do you think that would cause your pupils to open, dilate, or close, constrict? When do you need to be able to see really well? That's under sympathetic stimulus. So in a flight or fight situation, you need to be able to see as well as you possibly can to respond. And so it is sympathetic nerves that cause dilation of the pupil. So the pupillary dilator muscles are these little radiating muscles that come out like spokes and attach to the inner edge of the iris. And so what they're going to do is they're going to pull out like that, and they're going to basically stretch that pupil open. Those are under sympathetic control. Those are not controlled by a cranial nerve. None of the cranial nerves carry sympathetic fibers. However, the pupillary constrictor muscle is under parasympathetic control. And again, that is from the oculomotor nerve. So this little central rounded part of the muscle that you can see right there, that ring-like part, that's the part when it contracts, it gets smaller and constricts the pupil. Okay, so that's under parasympathetic control. All right. So much for the muscles, the intrinsic muscles of the eyeball. So we've got the ciliary muscles that can change the shape of the lens to accommodate light, to allow us to focus on things that are closer or farther away. And then we've got the pupillary dilators and constrictors that change the size of the pupil to change the amount of light that is allowed to enter the eyeball. Now, let's talk a little bit more about this process of accommodation that the lens can do, which really is what allows us to focus on objects that are different distances away from us. And again, this is called accommodation. So when we are looking at something closer up, so here's this focal point, first of all. Let me explain this diagram to you. This is obviously a cross section through the eyeball, right? So here's the cornea. This blue part represents the iris. So that's the pupil in the middle. Here's the lens, ciliary body with the little suspensory ligaments there. Here's the retina. And this is that fovea, that point of maximum acuity where we want to focus the light that's bouncing directly off the thing that we want to look at. Okay, so we're trying to focus the light right on that fovea. When things are close up, the lens, thanks to action of the ciliary muscles here, the lens bulges out. So in cross section, it goes from being flatter to being fatter, like that, bulges out. And that brings, increases the refractive power of the lens and brings those light beams into focus on the fovea. When we are looking at things that are farther away, the lens actually gets flattened out. So it goes from being like this in cross section to being more like this, becomes flatter. And when that happens, that allows us to focus light bouncing off of distant objects onto that fovea in the lens. So that's how that accommodation works. Now, we're all familiar, of course, you can see that I'm familiar with some vision problems. Vision problems are very common. Luckily, nowadays they're very, very easy for us to fix by wearing glasses or by wearing contact lenses or even by surgery. But there are some real common, two very common, or three actually very common types of vision problems that can be caused by differences in the shape of the lens or differences in the shape of the eyeball itself. So this is a picture of emmetropia, which is normal vision. So this is what we just showed you. So basically what happens with normal vision, as I said, is that the lens is able to shape those beams of light so that they directly converge. And as they converge, they all come together on that fovea, or that point on the retina, for maximum clarity. So there are three basic problems: nearsightedness, farsightedness, and astigmatism. Nearsightedness is what we call myopia. And that means that when it's nearsighted, that means you can see things that are close up, that are near, but you have trouble focusing on things that are far away. The reason for this is that there can be a couple of things that are wrong. The eyeball, or the lens, itself may be naturally too curved. So the shape of the lens is wrong, or the eyeball itself is actually too deep. In other words, it's sort of too long from front to back. In that case, the beams of light are focusing on a point that's in front of the retina. They will, of course, continue. These beams of light don't just stop at this point here in front of the retina. What happens is that they're going to continue back. They're going to cross. Let's see if I can get a little pen here. All right, now I'll try and do this. I'm not the best drawer on the screen. But these beams of light are going to continue, and they're going to cross through that point, and they're going to diverge again. So they'll pass through there, but then they'll begin to diverge. So by the time they get to the retina, they're spread out again. And so you're not going to have them all concentrated on that one point of the fovea. And so vision is going to be unclear. Okay, so the problem is that because that eyeball is too long, the light points are going, or the light beams are going to converge in front of the retina. And then by the time they get to the retina, they become to spread out again. This can be fixed by a lens that has at least one concave surface like that in front of the eye, and that helps to appropriately focus the light beams on the retina in the correct place. The opposite problem is called farsightedness or hyperopia. So myopia is nearsightedness, hyperopia is farsightedness. And what this means is that you do fine seeing things far away, but you have a harder time focusing on things that are closer up. And as you might expect, the problem is the opposite. Either the lens is naturally too flat, or the eyeball is too short. So here the eyeball doesn't extend far enough back. And so we have a similar problem. Instead of the light beams reaching a single point, converging at a single point on the retina, they essentially haven't converged completely yet when they reach the retina. So you can see that they're, I don't know if you can see that actually. You can see that they're still a little bit spread out right here as they reach the retina. So again, as those beams of light have not all converged on a single point, you're gonna, when they hit the retina, it's gonna be a little bit blurry. And of course, that can be fixed with a lens that is convex on at least one surface. So a glasses lens, that's what I have, in fact. Now, another problem that's related to this is a special type of hyperopia called presbyopia. Presby means old, elder. So Presbyterian church has to do with elders. Presbyopia is a thing that happens to virtually everybody as they get older, just like wrinkles and gray hair. What happens as you get older is that your lens actually gets stiffer. Okay, so the lens naturally as you get older loses some of its elasticity. This happens to a lot of the structures in our body. And once that lens gets stiffer, it can't bulge out as much. So if it's sort of staying like this in a resting position, remember that in order to focus on objects close up, it needs to bulge out, it needs to get fatter. It can't do that as well when we get older because it just becomes too stiff. And so what happens then is that you develop farsightedness. So similar to what we have right here, the lens is too flat because it's stiff, it can't bulge enough. And the light is not focused properly on the retina. It's sort of focused towards a place behind the retina. And so this, you're probably familiar with your parents. Probably your parents are now about my age, getting to the point where they can't hold their phone or whatever far enough away for them to be able to read it, okay? Because they have this type of hyperopia called presbyopia, farsightedness. And so that's when people might end up wearing bifocals if they had myopia, if they were nearsighted to begin with, but then they develop this type of presbyopia. They may need one type of lens for looking at things far away and another type of lens for looking at things close up. And that's why you get that divided lens with bifocals. Finally, the last common type of vision problem that's caused by things being shaped wrong is astigmatism. In the case of astigmatism, either the cornea or the lens is curved irregularly. So it's not just too fat or too thin, it's just kind of got a weird shape, an irregular shape. And in this case, the rays of light entering the eye aren't all going in the same direction. And so again, you get light beams hitting the retina in different places and you get blurry vision. This problem can also be caused or solved with glasses that have just the right type of lens as well. Okay, and as I said, you'll have another lecture where you learn a lot more about what happens after that light enters the eye and hits the retina and the neural processes that happen as those are translated into sight impulses in your brain. All right, so just to wind up a couple of lectures on the anatomy and innervations of the eye, here's a table where we can review exactly what cranial nerves are doing all of these different things. So as I said in my last lecture, there's a bunch of the cranial nerves are at least partially devoted to the eye. So remember that the optic nerve innervates the retina. The retina is really an extension of the optic nerve, and it provides us with our special sense of sight. The oculomotor nerve innervates the eye, but it's all motor innervation. That's cranial nerve 3. And remember, we've got two types of motor innervation: parasympathetic innervation to the intrinsic muscles of the lens and the eye, or the lens and the iris, excuse me. So that would be our ciliary muscles in the case of the lens, and our pupillary constrictors in the case of the iris. And then the oculomotor nerve also provides voluntary motor innervation to 4 of the extraocular muscles plus levator palpebrae superioris, which remember opens the eye, pulls up the upper eyelid. The trochlear nerve 4 and the abducent nerve 6 apply the other 2 extraocular muscles, superior oblique and lateral rectus. The facial nerve supplies parasympathetic motor to the lacrimal gland. Remember, tears causes the lacrimal gland to secrete tears, and voluntary motor innervation to orbiculus oculi, which squints the eye shut. And then finally, one that I haven't mentioned here before, but is also involved with innervation to the eyeball, is the ophthalmic nerve. That is what we call V1, or the first division of the trigeminal nerve. So cranial nerve 5, division 1, V1, the ophthalmic nerve. That's the nerve that provides general sensation to the orbit and the eyeball. So if I was to come up to you and poke you in the eye, that pain would be coming from the ophthalmic nerve. Or if someone blew in your eye, or you got a little eyelash in your eye, those feelings, those general sensations would be provided by the ophthalmic nerve. So here you can see the 3 branches of the ophthalmic nerve and the areas of skin of the face that they provide general sensation to. And the ophthalmic is V1 here. All right, well, that's all I wanted to talk to you about the anatomy of the eyeball, of the eye and associated structures. And if you have any questions about that at all, please feel free to go ahead and email me and I'd be happy to talk to you about any of it. I'll talk to you again soon.